here's Mrs. Lowy. Hello, Nita.
Such a good friend.
Here we go. Could you- The subcommittee will come to order. Good morning to all, and welcome to the Labor, HHS, and Education Appropriations Subcommittee. We are here today for another oversight hearing, and this time with administration officials and members of the department's Office of Inspector General to discuss the recently released report on the mental health needs of children in the care of the Department of Health and Human Services Unaccompanied Children Program. I want to thank our witnesses for being here today. And Maxwell, Assistant Inspector General, Office of the Inspector General, the Department of Health and Human Services, Jonathan Hayes, who is the Director of the Office of Refugee Resettlement, the Department of Health and Human Services, and Jonathan White, Commander, Public Health Service Commission Corps, Department of Health and Human Services. This hearing is really part of our oversight responsibility, which we take very, very seriously. We must. Considerable taxpayer resources are at stake, and something even more precious is at stake, and that is the mental and the physical well-being of children. That is why the Office of the Inspector General's new report was so alarming. It confirms our worst fears that intentional policy choices by this administration created what I would call a mental health crisis, which the Office of the Inspector General said that Health and Human Services and the Office of Refugee Resettlement failed to address. It is a crisis of deliberate, government-sanctioned child abuse. We must stop the trauma inflicted on these children. So I believe the administration must quickly implement the OIG's proposed recommendations, which are included in the report. The Administration for Children and Families has concurred with each of the recommendations, but words alone are not enough. The gaps created a mental health crisis as children are still dealing with the effects. As Ms. Maxwell summarized on page 8 in her testimony, and I quote, "Policy changes in 2018 exacerbated existing challenges as they resulted in, 1, a rapid increase in the number of children separated from their parents and entering the United States, many of whom were younger, and 2, longer stays in ORR custody for children," end quote. Those policy changes in 2018 were the administration's zero-tolerance family separation policy, which ripped children from their parents, and the administration's grossly intentional changes to fingerprinting and screening requirements that ground discharge to a halt. As a result, a child's average length of stay in government custody nearly tripled, from 35 days to 93 days. The numbers have improved since the administration began implementing its 4 operational directives in December to reverse their changes to the screening process. I will note that those changes followed a consistent drumbeat for accountability from the subcommittee. Now we need to see the agency's plan to improve the discharge process so that we are able to get children in and out of ORR's care as safely and as quickly as possible so they do not experience toxic stress and mental trauma. We do not only need a plan for bed capacity. And as I understand it, the onus with respect to discharge is on the grantees, and that's the contractor is responsible for the discharge consistent with policies, ORR policies and regulations. But the contractor is responsible. So ORR must then have policies in place that get children in and out of the facility as quickly as possible, because when Homestead, which is an influx facility, is charging $750 per night per child, the motivation to move these kids may not be as strong as it needs to be. There must be change, because as the OIG concluded, children have been suffering because of these intentional policy choices. Ms. Maxwell wrote in her testimony on page 9, again I quote, "Children who experienced longer facility stays exhibited higher levels of defiance, hopelessness, and frustration, along with more instances of self-harm and suicidal ideation," end quote. Also in her testimony on page 8, separated children exhibited more fear, feelings of abandonment, and post-traumatic stress than did children who were not separated. And the OIG's report on page 10 also described how some separated children expressed acute grief that caused them to cry inconsolably. In another story, the OIG's report shared that, quote, "A 7 or 8-year-old boy who was separated from his father without any explanation as to why the separation occurred. The child was under the delusion that his father had been killed and believed that he would also be killed. This child ultimately required emergency psychiatric care to address his mental health distress." It is terrible. And then the administration failed to fully or adequately treat it. As the OIG report spotlighted in its executive summary, quote, "Facilities struggle to address the mental health needs of children who had experienced intense trauma and had difficulty accessing specialized treatment for children who needed it. Overwhelmed by the deluge, clinicians reported caseloads more than doubled what they should have been. And unprepared for the younger children, those mental health providers who were available were primarily prepared to serve teenagers, not the mental and the social needs of preschoolers who cannot communicate their backgrounds, their needs, or even their pain." So as I read the OIG's report and testimony, the administration's intentional policies traumatized youngsters who then did not receive the proper care they needed. And I'll say it very honestly, I believe it is twisted and it is shameful. Let me add that we do not know the mental state of the children who were separated in 2017. That's a matter that is still in the courts. And understand, we only know about the 2017 children because of the Office of the Inspector General and the ACLU. And it's really very interesting to me as to, at the time of July in 2018, who made the decision to certify a list that was inaccurate. It was 2018, not what happened in 2017. What was the role? I don't know, Mr. Hayes, about your role. What factors went into making that decision? Now, we can also assume that the trauma of these children mirrors that of the children that the OIG identified in this report. It should add to the urgency we feel to stop the trauma. ORR is a child welfare agency, and we must be ensuring it is upholding its mission, which brings me to the OIG's recommendation. One recommendation from OIG is that ORR should take all the reasonable steps to reduce the time that children remain in ORR's care. I wholeheartedly agree. In fact, I will reiterate what I have been saying to this administration for months. Rescind the memorandum of agreement between the Department of Homeland Security and the Department of Health and Human Services. With respect to the agreement, the subcommittee has heard from outside witnesses and ORR grantees who said it continues to scare away potential sponsors who otherwise want to take care of a child but are too afraid to come forward. In fact, at our July hearing, Assistant Secretary Johnson agreed with the subcommittee that the memorandum of agreement should be rescinded. Since there has not yet been any action, it would appear that the responsibility to rescind the MOA is in the hands of the White House. Because if the administration wholeheartedly agrees with the OIG's recommendation here, then the administration must rescind the memorandum of agreement immediately. Another recommendation from the OIG is that ORR should identify and disseminate evidence-based approaches to addressing trauma. Again, I wholeheartedly agree. This subcommittee has repeatedly provided resources for the care of children in the appropriations bills that the House passed the last 2 years and in the emergency supplemental bill. With respect to the 2019 appropriation, I want to say a thank you to a ranking member, Tom Cole, then Chairman Cole, for accepting by voice vote my amendment to provide funding for SAMHSA, the Substance Abuse and Mental Health Services Administration, through the National Child Traumatic Stress Network, in what was a total increase of $10 million for the network, $4 million of which was for these children. And I just say clearly today that we need more funding to the stress network to deal with this issue. We are committed to ensuring ORR and HHS are upholding their mission to care for children, not to act as a tool of immigration enforcement, which is why we need to see the administration quickly implement the necessary changes, including the OIG's recommendations. Children did not just arrive at our border. They suffered by our hands, and they are suffering still due to the long-term mental health trauma. That is not something that we can ignore or that we can sweep under the rug. We need to stop the pain and the suffering. Caring for the most vulnerable is the most sensitive of our duties as members of this body and as a people of this great nation. There can be no greater sin than allowing ourselves to live by a lesser standard. So to close, I want to say a thank you to the OIG for this report, for your work. I look forward today to hearing more about it, hearing from the administration, and I hope to learn from HHS how you intend to to prevent the traumatization of youngsters as a result of the way I characterize it, the administration's cruel and heartless immigration policies moving forward. First, let me introduce my Republican colleague, the ranking member of the subcommittee, Congressman Tom Cole of Oklahoma, for any remarks that he would like to make.
Thank you very much, Madam Chairman, and I'm going to depart from my prepared remarks for just a second because I want to begin with 4 thank yous. And the first one's to you. Your focus on this issue has been unrelenting and I think appropriate. And while we may disagree over this or that interpretation, the fact is you've kept this committee focused where it needed to be on the welfare of these people, and you deserve all of our thanks. It is the right way to do oversight, and you've done it. I want to thank the IG. You know, we have IGs because my mom used to have a wonderful saying, "You're friends with the people that tell you what you need to know, not what you want to hear." And I think, Ms. Maxwell, you told us what we needed to know, and not necessarily what we wanted to hear, but I think that's your job, and you did it very well in this case, and I appreciate it. I also want to thank Director Hayes. I had the opportunity to travel to the border region with him over the August break, and I see a lot of effort to implement some of the changes and to be responsive to criticism and to correct the situation that we all agree. And finally, to a much maligned Congress, I want to give a thanks to the Congress. It took us a little too long, but we finally gave the administration the resources it needed in the emergency supplemental. And that hadn't solved every problem, but I can tell you things are a lot better than they were 90 or 120 days ago because Congress acted. Now, again, it took us 6 weeks. We did the same thing for President Obama in 3, but in the end, it was a bipartisan action by Congress that provided the resources that began to let us address some of the problems that Ms. Maxwell has very appropriately and I think wisely pointed out. We still have a long way to go, but this was a promising start. So with that, Madam Chair, I want to welcome our witnesses for the subcommittee's 3rd hearing on unaccompanied alien children program. Today, we're here to focus on the mental health needs of children in the care of the Department of Health and Human Services. Before we begin, I want to focus a little on the history of this program over the past few years. In 2012, this program received an appropriation of $169 million. This past year, the fiscal year 2019 appropriation, this committee provided more than $1.3 billion. In just 7 years, the appropriation for this program has grown by more than 670%. So there certainly has been a focus on it here. In 2012, the Department of Health and Human Services Office of Refugee Resettlement had over 13,000 children referred to them by the Department of Homeland Security. In the current year, HHS has had over 60,000 children referred to them for care. By the end of the fiscal year, HHS will likely have cared for over 70,000 children, more children than in any prior year. Again, in just 7 years, an increase of 370%. Pretty staggering. Both a Democratic and a Republican president have requested supplemental appropriations in the billions to support unanticipated arrivals of teenagers at our southern border. HHS now routinely cares for tens of thousands of children who travel thousands of miles, most coming from El Salvador, Guatemala, and Honduras. Objectively, this is a crisis and one that needs a comprehensive bipartisan solution. Federal law requires the Department of Homeland Security to transfer to HHS any unauthorized minor not accompanied by a parent or a legal guardian. This legal requirement means that when Customs and Border Protection or Immigration and Customs Enforcement apprehend a minor with an uncle, an aunt, a grandmother, grandfather, older brother or sister, the law defines that minor as unaccompanied and requires transfer of that child to HHS. I understand there are many who believe these children should remain with the adult relative they are traveling with. However, that's not the law of the United States, and that's probably something we should look at. I also want to address the topic of a zero-tolerance policy implemented by the Department of Justice in 2018. The administration has made several attempts to stem the flow of migration happening to our southern border. The zero-tolerance policy was clearly a mistake. And I'm glad that the president quickly ended it and the implementation of it. But the consequences continue. And while we may all disagree on the merits of such a policy, we can all agree HHS does not play a role in the establishment of immigration policy. HHS does not separate family. HHS does not separate children from their parents. HHS's responsibility is to care for children referred to them by DHS and to find suitable sponsors. And in that area, we've made considerable progress. As I said, many of these children are coming to our borders through Mexico from Central America. It's no surprise that such an arduous, dangerous journey is traumatic. Many of the children left family members, poverty, and dangerous conditions to come here. Once apprehended by DHS, the children are turned over to HHS to begin the process of finding a sponsor. For the short time the children are in HHS's care, they are provided with vaccinations, mental health screening, education, and legal information. Referral to mental health services can be a part of that process. The Office of Inspector General highlighted the challenges with meeting the mental health needs of the children in care. I want to point out that a significant portion of America, frankly, also faces the challenge of accessing mental health services. According to the Health Resources and Services Administration, 34% of the American population lives in a mental health professional shortage area. My own district alone has 22 such designated areas. So challenges facing adequate access to mental health services is something many areas are having to deal with. I'll just add parenthetically, when I was fortunate enough to be chairman of this committee and we had passed 21st Century Cures, there was a lot of mental health provisions in that. And the member most responsible, former member, Congressman Murphy, came to visit me, and I said, look, you've got multiple things here. I can't fund them all. You know, they're going to give me a finite amount of money. I'm not an authorizer. I got to live within a budget. Pick one or two things. And he hesitated for a minute. He said, number one thing is we just need more mental health care professionals. Anything you can do. Otherwise, we're just competing back and forth for a very small pool of professionals. And so we need to invest more in creating literally the healthcare professional service corps that we need. I also appreciate the desire for HHS role in the care of these children to be expanded. However, given the unprecedented surge in the number of unaccompanied children crossing our southern border, HHS's primary focus should be the establishment of state licensed and small facilities to care for children until placement with a sponsor is possible. And again, I want to commend you, Mr. Hayes. You've done a lot more of that in the last 60 to 90 days, and that's been very helpful. I know that my friends at HHS are doing their best that they can with a challenging situation. I want to commend them for the difficult work they are performing. and note that they are facing, again, many of the same challenges faced by the prior administration. It's my hope that this committee will work with them in a bipartisan fashion to provide the resources needed to confront this urgent challenge. With that, Madam Chair, I yield back my time.
Thank you very much, Congressman Cole. I'd like to yield to the ranking member of the Full Appropriations Committee, Congresswoman Nita Lowey of New York.
She's like the chairman.
What'd you call me? You can call me anything.
I said the chair of the Appropriations.
Oh, you said the ranking member.
Make no mistake. She is the chair.
I thank you, Madam Chair. My friend for a very long time. I want to thank Chair DeLauro, Ranking Member Cole for holding this hearing. And I thank Assistant Inspector General Maxwell, Director Hayes, and Commander White for joining us today. The fact that we're here again today is a clear example of how damaging and cruel the Trump administration's actions have been on the mental health of vulnerable children. This could have been largely avoided. Children belong with their parents. Now, many of us have read this article in the New York Times, July 30th, 2019. And it says, in testimony before Congress earlier this month, the Border Patrol's Chief of Law Enforcement Operations, Brian Hastings, said the agency has established that its agents may elect to separate a child from a parent if there is a determination that the parent or legal guardian poses a danger to the child, is otherwise unfit to care for the child, has a criminal history or a communicable disease, or is transferred to a detention setting for prosecution for a crime other than improper entry. 70,000 children have been separated from their parents. I'm going to say a few more words, but I find that astonishing. 2 months ago, Chair DeLauro and several of our colleagues visited the Homestead influx facility. As I looked through the Inspector General's report on mental health needs of these children, it's clear we were not provided a full picture of OR's challenges. I'm deeply concerned with the Inspector General's finding. Some of these include clinician shortage problems with access to external and specialized care, and a lack of preparedness among clinicians to treat the level of trauma in these children. What causes me even more concern is what we still don't know. Now, I just want to repeat this again, because then that was, okay. I have just been corrected by my distinguished chair. Okay, I just want to conclude by saying whether it was 70,000 or this number is wrong, or I'm not going to debate that now. But my prime concern, no matter how clean Homestead was, no matter how many smiles were on the face of everybody, no matter how many books they were given to read, no matter how many toys they were given to play with, I just feel very, very strongly that children belong with their parents. And to leave it to the Border Patrol, who may elect to separate a Border Patrol person, who may make the decision to separate a child from a parent, that Border Patrol person is making a decision as to whether the parent who brought the child here should be taking care of the child, better putting it in a facility away from their child. This just doesn't make sense to me. And I cannot believe, and we met many of those children, I cannot believe that the parents of all of those children were unfit to take care of that child while they're waiting for a hearing. So let me just say, it is clear that although we visited this facility and we saw some good things, but we saw many things that had to be corrected. I just want to conclude again, because as good as your clinicians are, and they may be fine people doing the job, you can't tell me that thousands and thousands of children are better off in a facility, as clean and as smiling the people are, than being with their own parents. So that's really my point.
Thank you very, very much, Madam Chair. We're now going to proceed to the opening remarks from Ann Maxwell, again, Assistant Inspector General, Office of the Inspector General of the Department of Health and Human Services, followed by Jonathan Hayes, Director of the Office of Refugee Resettlement, Department of Health and Human Services. And we are also joined by Commander Jonathan White, the U.S. Public Health Service Commissioned Corps, who will be available to respond to questions. Ms. Maxwell, welcome, and thank you for being here today. Your full written testimony will be entered into the hearing record. You are now recognized for 5 minutes.
Good morning, Chair DeLauro and Ranking Member Cole and other distinguished members of the subcommittee. Thank you for the opportunity to discuss OIG's ongoing oversight of the Unaccompanied Alien Children Program administered by the Office of Refugee Resettlement. Today, I'll be focusing on our findings regarding the challenges ORR-funded facilities face in addressing the mental health needs of children in care. These facilities serve migrant children who arrive in the U.S. on their own or who are separated from their parents by immigration officials. These children have often experienced intense trauma before coming into ORR care, which is why prompt mental health treatment is not only required by ORR, but is essential for child's well-being. My testimony reflects what we heard firsthand from facility staff across the country about the obstacles they face. We were told that there are a number of systemic challenges that make it difficult for staff to address the mental health needs of children. These include the ability to employ and support clinical staff. Mental health clinicians reported heavy caseloads. They also asked for more training and support to treat traumatized children. In addition, staff faced difficulties in accessing specialty care, such as psychologists and psychiatrists, to treat children with greater needs. In one example, the only bilingual specialist that a facility could locate was in a neighboring state. Finally, staff reported a lack of therapeutic placement options within the ORR network that were equipped to treat children who needed a higher level of care. This was especially acute for children who needed secure therapeutic settings due to their history of behavioral problems. To address these systemic challenges, we recommend that ORR leverage the expertise and resources within HHS and the broader mental health community to ensure facilities have sufficient clinical staff who are fully supported and able to access the needed specialty care for children. These systemic challenges, according to staff, were exacerbated by policy changes made in 2018. In the spring of 2018, the Department of Homeland Security formally adopted the zero tolerance policy of criminally prosecuting all adults for illegal entry and placing their children in ORR facilities. Facilities reported that addressing the needs of children separated from their parents was particularly challenging because the children exhibited more fear, more feelings of abandonment, more post-traumatic stress than children who were not separated. One medical director told us that separated children would present physical symptoms as manifestations of their psychological pain. These children would say their chest hurts, even though there was nothing wrong with them medically. One child even said, "Every heartbeat hurts." These children didn't understand why they were separated. As a result, some were angry, believing their parents had abandoned them. Others were anxious, concerned for their parents' safety. One 8-year-old boy, who the chair talked about, separated from his father, was under the delusion that his father was killed and that he was next, and he required emergency psychiatric care. Caring for separated children was additionally challenging because they were often younger than the teenagers the facility were used to serving. Staff reported younger children had shorter attention spans, needed greater supervision, and more commonly exhibited defiance and other negative behaviors. They couldn't always accurately communicate. The little ones, as one program director said, don't know how to express how they're feeling. There were other policy changes in 2018 as well, and these involved the process for discharging children to sponsors. OR added new screening requirements and started sharing sponsor information with immigration officials. Staff noted that these changes led to longer stays in care for children, and that had a negative effect on their behavior and their mental health. They said even children who entered care with good coping skills became disillusioned as their time in care dragged on, resulting in higher levels of hopelessness, frustration, and more instances of self-harm. While the policy changes made in 2018 have largely been reversed, facilities continue to serve separated children as well as children who are not quickly discharged from care. To address these continuing challenges and to ensure that children are not unnecessarily harmed, we recommend that OR continue to reassess whether its current policies are negatively impacting children in any way and adjust as needed. We also recommend that OR establish guardrails that ensure that future policy changes prioritize child welfare considerations above all other competing demands. Thank you to the committee for the opportunity to present this information and your ongoing support of our oversight. It's greatly appreciated. I'm happy to answer any questions you have.
Many thanks. Director Hayes, welcome back. Thank you for being here, and again, your full testimony will be in the record, and so now I will recognize you for 5 minutes.
Thank you, Chairwoman DeLauro, Chairwoman Lowy, and Ranking Member Cole, members of this committee. It is my honor to appear today on behalf of the Department of Health and Human Services. My name is Jonathan Hayes, and as the Director of the Office of Refugee Resettlement, I oversee the Unaccompanied Alien Children Program. I am joined today by Commander Jonathan White, an officer in the U.S. Public Health Service who is currently assigned to the Assistant Secretary for Preparedness and Response at HHS. Commander White served as the Federal Health Coordinating Official for the interagency mission to reunify children separated from their parents in ORR care as of June 26, 2018. He also previously served as a Deputy Director at ORR. He has not prepared testimony, but is here to answer your questions. Thank you for the opportunity to discuss with you today the HHS Office of Inspector General report titled Care Provider Facilities Describe Challenges Addressing Mental Health Needs of Children in HHS Custody. HHS is committed to addressing the mental health needs of the UAC and the care of ORR. We welcome the report as we continually improve the mental health services provided to the children in our care. ORR operates nearly 170 state-licensed medical care provider facilities and programs in 23 different states. ORR has different types of facilities in order to meet the different needs of the minors in our care. In addition to our traditional state-licensed facilities, ORR also operates influx care facilities, which receive UAC when ORR's licensed bed capacity is strained by surges of referrals or in a case of a natural disaster or other emergency. HHS has detailed policies for when children can be sheltered at a temporary influx care facility. Mental health services are available at all of our facilities. ORR policy requires at a minimum that UAC and ORR state licensed facilities receive an individual counseling session and 2 group counseling sessions with a clinician every week. Additional mental health services are available as needed. The children in ORR care have a unique set of needs. We provide services to children from a wide range of backgrounds and cultures who speak a variety of languages. As documented in the OIG report, many of the children placed in ORR care have experienced severe trauma. The mental health professionals working with the children must be bilingual and be qualified to assist traumatized children. Yet the OIG report acknowledges the general shortage of qualified practitioners nationwide. The qualification requirements create difficulties in both recruiting on-site staff as well as finding referrals for additional services in the communities around the facilities. One challenge identified in the report is that some clinician staff told the OIG that they are often unprepared to assist children with the severe trauma experienced by UAC. Treating children with severe trauma is complicated and is only made more complicated by the relatively short time of children residing in ORR care. Some clinicians told OIG that they were concerned about asking children to revisit their trauma when it was unclear whether the child would be in our care long enough to make progress in addressing their trauma fully. ORR's mission remains to unify children with a suitable sponsor as expeditiously and safely as possible. For this reason, most children do not stay in ORR care for very long. Based on the clinical expertise of the mental health professionals on staff, the focus of mental health services has been to stabilize children and to provide them with a sense of security. However, program staff assess each child's mental health needs and provide additional services as appropriate. ORR is working to provide clinicians with tools to strengthen mental health services. Recently, ORR collaborated with the National Child Traumatic Stress Network, or NCTSN, to develop a 4-part webinar series on addressing trauma in UAC. ORR is continuing to work with the NCTSN to develop additional resources. ORR also offers post-release services to some UAC. If a child needs additional mental health services after they leave ORR care, a post-release services caseworker will work with both the child and the sponsor to find services in their community. ORR is working to expand the number of UAC that receive post-release services. I believe that a child should not remain in ORR care any longer than the time needed to find an appropriate sponsor for the child. A central part of ORR's mission is to discharge children from our care as quickly as possible while still ensuring the safety of the child. At the time that OIG conducted its visits, the average length of care was 83 days. It is now 50 days, a 40% reduction. ORR will continue to assess the efficiency of its operations to improve the process for release and reduce the time that a child remains in our care in custody. My top priority and that of my team is the safety and well-being of the children in the temporary care of HHS. We welcome this report because it explained the services that ORR currently provides and identified the obstacles that we face in providing those services. My team is ready to face those obstacles and overcome them with help from our partners and with the continued support of Congress. Thank you for the opportunity to discuss our important work. Commander White and I will be happy to answer any questions that you and your committee may have. Thank you, Chair DeLauro.
Thank you very, very much. Let's get right to the questions here. Ms. Maxwell, you note that the policies that traumatize these children have largely been reversed. And I just pick up your quote at the end of your remarks, but you say that facilities still face challenges addressing the trauma of separated kids, and that we ought to pay attention to that and to the deteriorating mental health of the kids who remain in care. The policies have been reversed. What are still the challenges, and what are the policies that ought to be examined going forward?
Thank you, Chair, for allowing me to clarify that point. Yes, the additional challenges that facilities faced in 2018 continue to be a concern despite some of the policy reversals. First of all, facilities continue to provide care for separated children. So the court order, as you mentioned, that stopped most separations, allows for separations under certain conditions.
There are separations. Okay.
Absolutely.
Go ahead.
And the federal government recently certified to the court that there were 911 children separated from a parent over the last year. In addition, with respect to lengths of stay, ORR did reverse the additional sponsor screening requirements, and the length of stay fell. However, they continue to share information about sponsors with DHS according to the 2016 MOA. And again, as you mentioned, there are concerns that that has a chilling effect on finding sponsors, which is why we recommend that ORR review all of its current policies to see if they present any unnecessary barriers to releasing children to appropriate sponsors and adjust them as necessary.
Thank you for the clarity on that issue. Let me move to Exhibit 2 on page 12 of the report. Shows how the number of young children referred to are sharply increased as a result of family separation. I want to put this information into the record. ORR facilities typically serve teenagers. So answer to this question. Did facilities and grantees have the right tools to adequately provide mental health services for younger children?
Not according to this clinical staff that we spoke to. They told us that they, as Director Hayes had mentioned, that they expressed their concerns about being able to treat children who had encountered intense trauma before coming into care. Now, this is a concern they had in terms of treating all children. They noted it was additionally challenging treating younger children who had different needs and different therapeutic needs and had less attention span. So we recommend, again, that ORR help these facilities, help the clinicians by identifying and disseminating evidence-based, trauma-informed short-term therapy for children of all ages.
Thank you. Commander White, earlier the subcommittee held a hearing with Dr. Althus Stewart, who's president of the American Psychiatric Association, told us about toxic stress. Highly stressful experiences like separation of children from their family is resulting in toxic stress can cause irreparable harm. I respect the testimony that I've heard that you have provided in previous hearings and the warnings that you gave to HHS officials about the traumatic impacts of family separation and the effect on children. Let me just ask you, with your medical background, with what you know about the children who end up in ORR's care, what can you tell us about toxic stress that affects these children as a result of the trauma they've experienced in their countries of origin, during the journeys to the United States, and as a result of family separation?
Thank you, Madam Chairman. So to be clear, the UAC program has long been trauma-informed and is designed to serve unaccompanied children. That is an enormous challenge. It is an enormous challenge, but it is dwarfed by the unique challenge of separated children. And as I've testified in front of other committees, and I will say again today, it is, in my professional judgment, impossible to build a program that can respond appropriately to the needs of separated children. The only way to address that trauma is prevention. And this speaks to the need for a coherent legislative fix to define those conditions under which it is permissible to separate a child from a parent at the border, to have appropriate rights and remedies for parents who experience that. The UAC program is the right place for children who enter the United States unaccompanied, but neither it nor any other federal program I could imagine can respond to the recentness, the severity, the toxicity of the trauma of separation from parents, particularly when the clinicians themselves will be seen by the children as part of the very system that separated them.
Thank you. I am going to go for this last comment here. You have Exhibit 3, page 13 of the report. Length of stay in ORR custody spiked after HHS signed the MOA with DHS. So, Ms. Maxwell, according to the mental health clinicians your investigators interviewed, what are the mental health effects on children staying in ORR custody longer as a result of the memorandum of agreement?
What we heard from clinicians in the field were that children who did not initially exhibit mental health or behavioral issues began reacting negatively the longer their stay wore on.
So the longer children stay in care, the longer they are traumatized. I may make a final comment here. As long as the MOA is still in place, there are sponsors who are terrified of coming forward. It was at our July hearing, Assistant Secretary Johnson agreed that HHS should be terminated. As long as this MOA is in place, HHS is unnecessarily extending ORR custody for children, which further traumatizes them. The MOA must be rescinded.
Thank you very much, Madam Chair. Ms. Maxwell, let me start with you, if I may. You had some really valuable, I think, and very helpful information on the damage done in terms of family separation to young children. We obviously have a larger population that is unaccompanied, and so they don't go through that. But if you could distinguish, and the last testimony actually probably did a pretty good job of this, but that second population, which we are dealing with in very large numbers, what are the differences that you see between, obviously, family separation, which I think we all agree was a bad mistake, and obviously the more normal situation that we're now dealing with of unaccompanied children? Are they traumatized to the same extent, or?
Yes, thank you for that question. Our report largely deals with the entire population of children that the OR facilities have to provide mental health care. Most of the challenges that we heard about were, in fact, systemic challenges that affected all the children in care. And we heard again and again that all the children in care suffered, severe trauma in home country during the journey, and that some children experienced the additional trauma of unexpectedly being separated from their parents. But as we move forward with our recommendations on practical steps that OR can take to address these systemic challenges, we have designed them such that they would help improve the mental health care for all the children that OR facilities are responsible for caring for.
Thank you. Director Hayes, could you give me some idea of the steps that you've taken to respond to some of the suggestions and recommendations that the IG has placed in front of you?
Yes, sir, Congressman, happy to. So again, we are working on a number of things in response to the OIG's report. We already are working on developing an intern program with colleges and universities in order to place interested students in ORR programs with hopes that they will one day come and join us as professionals postgraduate. Additional funding for continuing education to licensed clinicians as a retention strategy is also something that we're undertaking. We're working to expand our presence at job fairs across the nation in order to find needed clinicians and case managers to work in our facilities, although I will note that a number of those job fairs have been protested and some of the staff potential staff verbally threatened, and so that is not helpful. We've also partnered with the National Child Traumatic Stress Network, the NCTSN, to develop a 4-part webinar series, as I referenced in my testimony, on trauma in the UAC. And in April of 2019, we also hired a board-certified adolescent and adult psychiatrist that is employed inside of the Division of Health of Unaccompanied Children at ORR.
Well, I commend you for those steps. I'm going to go back very quickly to Ms. Maxwell. Do you have a mechanism to follow up? I think there's a good faith effort going on at ORR to try and respond, but it's important, obviously, that we have, as you provided us, sort of an outside view to make sure that process continues.
Absolutely. Thank you. We are happy to see the steps that OR has already committed to, some of which they've already undertaken. So that's a good start. But yes, our process is to always follow up the recommendations and be in conversation with the department to ensure that all of the commitments that they made are fulfilled and are fulfilled to sort of the spirit of the recommendation as well. So we will continue to work with the department to make sure.
And I hope you stay, and as I know you will, stay in touch with this committee, because obviously at the end of the day, we've got a resource requirement here. Let me go back to you, if I may, Director Hayes. It's got to be extraordinarily difficult to get the personnel you need. We know that, as I mentioned earlier, just in terms of mental health for the entire population. In this case, you need bilingual professionals, I would suspect, in many cases. There can't be a ton of those, particularly in a lot of the areas that you have your shelters. So, I mean, number one, what are you doing? What level of success are you having?
So thank you, Congressman. Yes, to your point, the Flores Settlement Agreement does require the majority of our shelters to be in the area where the majority of the children are apprehended, Southeast Texas, the Northeast Corridor, Southern Florida, and Southern California. And so, there is a challenge in those areas to identify and retain, some of the licensed clinicians that we need. We are looking to expand outside of some of those areas. We worked very closely with keeping the committee staff informed on our efforts to look into larger metropolitan areas where we can have some of these smaller and medium-sized shelters, and hopefully tap into a fresh pool of clinician staff. Although we are seeing some resistance to that, even right here in our own backyard in D.C. and Northern Virginia. Again, at the expressed desire of Congress to open up more smaller and medium-sized shelters that are licensed, we're seeking to do that and not really receiving a lot of support, actually opposition by both D.C. and Northern Virginia. So we'll continue to look in other areas and expand outside of that where we can pull, from the local community the needed licensed clinicians and case managers and youth care workers and other support staff that we need.
Thank you very much. As I advise you, Madam Chair, I'm going to have to step out, but I will be back. So,
Chairman Lowy.
I, too, want to apologize. I am called to another hearing. I just wanted to thank you all for your thoughtful comments, and particularly Jonathan White when you talked about the severity toxicity, separation of children. And I just want to read this quote again because as a mother of 3, grandmother of 8, I can't imagine that these children who were brought here by their parents for whatever reason are being separated. So, if the New York Times is saying, since the president officially ended family separations, authorities have removed more than 900 children from their families. More than half of the children, 481, were under the age of 10 at the time of separation. 185 of those were under the age of 5. The administration is still doing family separation under the guise that they are protecting children from their parents, even though the criminal history they are citing is either wrong or shockingly minor. So I want to thank the chair for having this hearing again. Thank you for your good work and trying to do the right thing, but this policy is outrageous, and I do hope that we can all work together to change it. Thank you. Thank you, Madam Chair.
Thank you, Madam Chair. Congressman Harris.
Thank you very much, and thank you, Madam Chair, for calling the hearing, about, caring mental health care. So I need to ask, and I don't know, I guess maybe I'm going to read it there, Commander White. That's right. Yeah, it's not on there, but it's on your arm. Oh, it's in small print. I'm too old to read that far. You're a licensed clinical social worker. You understand the lack of mental health professional availability in the United States. In fact, as the ranking member had said, according to, I believe it's a HHS report, they designated shortage, there are 111 million Americans who live in shortage areas, designated shortage areas. 60% are in rural areas. My district is largely rural areas. So I'm going to estimate that I have tens of thousands, if not hundreds of thousands of people who live without adequate mental health coverage. Is that something that you appreciate, that there are a lot of Americans who don't have adequate mental health care?
Congressman, there's no doubt that nationwide, all of the evidence that we have and everything that our department has produced for many years affirms there is not enough mental health workforce. There's also particular deficiencies from many geographic areas. And in the case of the children we serve, there are also additional challenges both for those children and for anyone who needs culturally and linguistically appropriate services that those with mental health needs from Central America would have. These are national problems. They're amplified for us because these children are a federal responsibility. But this is a giant problem.
Sure, but as policymakers, we always have to balance. When we have a limited resource like health professionals, where are we putting them now? It says, I guess, in the IG's report that, and I guess this is true, ORR requires each facility employ at least one mental health clinician for every 12 children in care, a ratio of 1 to 12.
That is correct.
Wow. In Baltimore City, remember, where there's one murder a day, where I'll bet you almost every student knows someone who's been killed or some family who's had a murder a day, the ratio of counselors in schools, mental health counselors to students, is 980 to 1. 12 to 1 sounds pretty good. How are we at getting to that goal? Because I don't know. You must be doing tremendous recruiting, because we can't recruit into inner cities in Maryland where we have students who unquestionably have the need for mental health care, unquestionably. So where does 12 to 1 come from? Because it seems like it's a pretty low ratio compared to the 980 to 1 that are in Baltimore City schools, and the 250 to 1, which is recommended nationwide for school counselors. And again, Baltimore City has more problems. These children are exposed to trauma every day on their streets. It's a lawless environment. The president is absolutely right about Baltimore. Where does the 12 to 1 ratio come from?
Dr. Harris, the ratios of 1 to 12 for clinicians, 1 to 8 for youth care workers, and 1 to 8 for case managers is inside the ORR policies and procedures. Perhaps my colleague, Commander White, can speak to some of the historicity behind that, but that's specifically spelled out in our policies.
And you hit that ratio? I mean, you do have a 12-to-1 ratio.
We do, yes, sir.
Congratulations, because it's much better, much better mental health care than exists in other high-risk populations, again, like Baltimore City schools, students. There are two categories of children who ORR takes care of, general categories. Ones who have been separated by their parents because they're unaccompanied children. I mean, some relative of theirs decided to send this child across a trek to I don't know, you can't call it self-separation because these children had nothing to do with it. And then you have the family separation that occurred at the border under laws. What's the ratio? What's the highest it's been, and what is that now? Of those two, I'll call them patient groups. I'm a doc. Patient groups.
So, Congressman, I don't have the specific numbers. We'll be happy to work with your team to to get the specifics out. But I can state, the overwhelming majority of the children that are in our care, the absolute overwhelming majority, are not children that we considered separated by law, meaning they came across the border either unaccompanied or with someone other than a mom, dad, or
the overwhelming majority. So how do I explain to the people in my district who don't have mental health care that we have a 12-to-1 ratio in these facilities when the vast majority of children are there because their parents chose to separate them or their relative chose to separate them, and I don't have it? And that's a rhetorical question. You're not going to answer that. I tell you, 12-to-1 ratio is great. I congratulate you on being able to find those professionals because we can't do it in my district. Madam Chair, I yield back.
Congresswoman Roybal Allard.
For a long time, one of the things that has troubled me is the overuse of psychotropic drugs in our foster care system. So when I read press reports indicating forced use of these drugs in OR custody children, I found it to be extremely disturbing. And while the OIG report showed the percentage of children in OR custody who had been prescribed psychotropic medications was lower than in the general population, there are still 300 or more children currently prescribed medications that can have significant impacts on their psychological development without any family involvement or consent. Ms. Maxwell, what percentage of the children reported to be taking these psychotropic medications in your report came into OR custody already on these medications? And did your report quantify how many of the children receiving psychotropic medications were taking 2 or more medications?
Thank you for that question. We do not have those specifics. So we were talking to their case managers and the medical coordinators that prescribe those medications, and we have the statistics about who was taking medications in care. And as you mentioned, it was about 1 in 30, about 300 children in the 45 facilities we visited were on those drugs.
Okay. Commander White, I think this is a very serious issue, particularly in terms of follow-up children who are on these drugs and then are released. It can have serious consequences if they aren't monitored and either continue with the medication or are brought down from it. Since OIG did not independently review the medical records or assess the appropriateness of the medications that were prescribed for these children, who would be the proper person or agency to go and make these reviews?
In just a moment, I'm actually defer to Mr. Hayes as the director because policies have evolved since I left ORR. But within ORR, there is a team of the Division of Health for Unaccompanied Children. They are career public health service officers like myself. They are board-certified pediatricians, epidemiologists, pediatric psychiatrists, and nurses. And the supervisory role for the medical care of children, and also the processes whereby children are discharged with a plan for continuity of care is ultimately their responsibility. But I'll defer to Mr. Hayes to talk about the current policy.
Yes, so Commander White answered that question accurately, ma'am. That's how I would have answered it as well. And I'll just state that when I became the acting director at the very end of 2018, I delegated those medical type decisions to our deputy director over children's programs and her medical team as the both medical and child welfare experts.
And so how often does that person review the medical records of these children to make sure that they are prescribing the appropriate amount, and when the children are released, that their follow-up records are also appropriately done?
Yes, ma'am. So, Congresswoman, specific to medication prescribed, I don't have details into that. Again, that's something I would defer to the, to our medical doctors on staff. But I would say that the professionals that Commander White mentioned, that is an ongoing daily discussion across a myriad of issues with all of the medical professionals at each of our shelters, a coordination effort back and forth with the Division of Health of Unaccompanied Children here in D.C. So it's an ongoing process.
Okay, so when a child is released, then does that medical expert then review the record and the plan for that child when that child is released? On a case-by-case basis? How does that work?
Particularly for minors who have higher acuity medical needs, including higher acuity behavioral health needs like you're talking about, it would be standard to have a member of that team work with the treating physician and treating medical team in the child's program on a plan for effective transition for continuity of care as the child exits the program. That's ultimately bounded by the realities of what kinds of care actually exist out in the community, which is something we don't control, but absolutely yes, that is a very high priority for physicians on that team.
And if I just may add, Congresswoman, that could be a situation where if there is a strong medical need, that would be something where our grantee team and our project officers would work for some post-release services to identify some community-based resources, to Commander White's point, again, to ensure that continuity of care.
Okay, and is there, does the insurance, if, say, a sponsor, the release to a sponsor, are those medications covered by insurance? Maybe not every insurance.
So different sponsors will have different degrees of family access to the healthcare system. We in HHS do not fund ongoing access to healthcare. We're not appropriated to fund ongoing access to healthcare for discharged minors. Minors are discharged with a supply of medication, a referral to services in the community, and part of the case management plan with the sponsor and the child is to identify how they will get those needs met in the future. But the broader healthcare system is as it is.
Okay, and I'm over, okay. Okay, I've got plenty of questions.
Congressman Molinar.
Thank you, Madam Chair, and again, thank you for having this hearing, and I want to welcome all our guests, and I wanted to thank you also for reappearing before the committee and participating in this way. I wanted to, just build on some of the discussion that has already occurred on the, the health professional shortage areas. Obviously, we're concerned about people getting good access to mental health services, and of course, these children, given what they've been through, would want to really make sure they are well served. And the ratios that we were talking about, as some of our colleagues have mentioned, it's a challenge all over the country. And my hope is that ORR has been working with colleagues in HHS to kind of look at what we're learning on a national scale and applying it to this situation as well in order to, expand these resources and make the most. One area, and just in context of my district, is in rural Michigan. We actually have 62 health performance professional shortage areas, which is pretty significant. So we're dealing with this in rural Michigan. A couple of things we're looking at is, kind of innovative ways to partner with state, federal, and local agencies to maximize the resources. Another thing we're looking at is telemedicine and, technology where, you know, people don't have to travel great distances, and you're able to act. Have you looked in this situation at the use of telemedicine, where it may be beneficial, where it wouldn't be helpful? Because I'm viewing that as a tremendous way of you know, giving people the resources they need and specified treatment. But I want to get your perspective on, you know, what the potential is for that.
So I don't have specific numbers, Congressman, but I will say that we do utilize some telemedicine practices inside some of our shelters to help, you know, meet some of the ratios that are required. So,
And do you feel that, you know, I know it requires technology, it requires, you know, in our case, rural broadband access in every area. But what strikes me is you're talking people who speak different languages, people who have different cultural, and the idea that you could tailor that and have professionals from all over the country being available to, that could be helpful, but I you know, I don't know the limits of that.
well, Congressman, I just, you know, one of the things I pointed out in my testimony, and as did Ms. Maxwell, you know, one of our requirements is that you are a bilingual to be one of our grantee staff, and obviously have just that cultural understanding of, you know, where the children have come for as well. So that's a requirement. So that actually even further narrows the window of licensed clinicians that we have available, you know, again, having to be both meet our educational standards and experience standards, but also be bilingual.
Are there any resources you would need to expand opportunities for telemedicine?
You know, I'm sure there could be some, sir. I don't really have any at the top of my head. Be happy to circle back with
Okay,
you.
I'd be very interested in that. It's something we're dealing with in rural Michigan, and we're kind of seeing areas where it has tremendous potential, areas where it may not so much, but, you know, I think, and the other question I had are, you know, are you looking at sort of partnerships with states and local entities that could help improve the situation?
So I would say one thing. I'm going to go, you know, back to my the division director of health for unaccompanied children and ask the telemedicine question, and so we will get back to you on that. So, you know, again, sir, you know, my goal and the goal of Assistant Secretary Johnson and Secretary Azar is to, you know, increase our permanent network capacity so that we, you know, have available permanent state licensed beds for all of the children that are referred to us from our federal partners. And to that end, that requires a partnership with the local and state governments. And we welcome local and state governments to partner with us in this mission to care for these very vulnerable children. And again, you know, we're seeing some resistance to that with certain communities, and I wish that wasn't so. Because again, we want to be able to have, as directed by Congress and as the expressed desire of the leadership of HHS, as many state licensed permanent beds available to meet the needs of these kids without having to rely on emergency influx beds.
Okay, thank you very much. I yield back.
I'm going to take a prerogative here before I introduce Congressman Pocan. I would just say that if we had a discharge plan that was adequate and moved these children out quickly, as we said earlier, that the longer they're there, the more traumatized they are. It's not about building the capacity for beds. It is about building the capacity and a discharge plan to be able to get them out of the system in a safe place, as the mission has said, expeditiously as possible. Might also add that if you want to increase professionals, increase the reimbursement rates, stop private contracting, and look at some of those issues in terms of increasing professionals. And in terms of the amount of services and the dollars where you can find opportunity for different kinds of services for the children who are there, including mental health services, we just appropriated $2.9 billion. There ought to be room in there to be able to fund some of these efforts. Congressman Pocan.
Thank you, Madam Chair, and thank you all for being here today. I appreciate it. You know, this is certainly a sad stain on our nation's history of what's happened with this period, and we're not through it yet, so we appreciate you all being here today. Mr. Hayes, I have a question for you. It's a yes or no. Do you agree that the Trump family separation policy has had a negative impact on your agency's ability to meet its legal mandate to provide mental health care to unaccompanied children? It's a yes or no.
Could you reframe or repeat the first part of that, sir? I'm sorry.
Sure. Do you agree that the Trump family separation policy had a negative impact on your agency's ability to meet its legal mandate to provide mental health care to unaccompanied children?
I agree that the separation of young children from their families created a difficult environment at the Office of Refugee Resettlement, which I stepped into in June of last year, sir.
Yeah, I appreciate that because when we read the report, and I know you've obviously read the report, and hear of things like having to go to a neighboring state for a bilingual specialist. I mean, clearly we know where these kids are coming from. Like this should have been. It's not even a 101. It's kind of a remedial level of providing assistance to folks. And again, it's very sad that this happened when you hear about a 7 or 8 year old child thinking they're about to be killed because of this policy. You don't get much worse, I think, as far as government policy doing things like this. I have a question just to kind of bring it back. So we all went to Homestead, and we appreciate your time there, and since then coming to the committee. But to get back to why and some of the conditions that put children in this place, people back home still, to this day, cannot understand how we spend $750 a day to house children for really long periods of time until we made some policy changes recently. And we had 3,000 plus kids at Homestead. When for $750 a day, you could go to Four Seasons, any Trump hotel, which I'm sure he would have enjoyed. The fact that we finally got the children out very quickly just doesn't pass the smell test back home. Why it took so long for so long. People were making a lot of money in a private facility at $750 a day. And then suddenly we're able to move folks. But at the very end, there were a couple hundred kids that were literally in the middle of the night whisked away. Can you address that couple hundred children that in the middle of the night were whisked away on the final day?
Yes, sir. So one thing, I think you referenced a number of well over 3,000. There was
Was it
a number
2,700 or something?
The highest number was around 2,620. I don't know the exact
2,620?
number.
Okay,
That was the
2,620.
highest. I just want to clarify
Pretty
that.
disgusting number nonetheless, correct?
Well, again, it was based on the numbers of children coming across the border.
Due to the policy that we've all agreed has put us in a pretty
These are
awkward
numbers that
place.
started in January of this year and escalated up until June, until when the referrals dropped. And that's the reason I'm answering that way, Congressman Pocan, is because that was one of the effects on the ability to empty out Homestead, which is the sheer drop in mid-June of referrals coming across the border.
Well, just because one of the girls I talked to, she had been there 60 days before, the week before they finally reached out to her brother. So for 50-some days, a company made a lot of money not doing their job, which was to try to place that person outside. And again, when I tell that story back home, people can't understand it. But the 200 people whisked away, I'm just trying to figure that out because it's something, it's a question for a lot of us.
I asked for the percentages of kind of the last 30 to 45 days at Homestead. And
The last night, I'm talking about the middle of the night, the last
but
couple hundred.
I answer that, sir. Well over 80% of the children that were discharged from Homestead were released to their family. Or
Right, that
sponsors,
wasn't my
right?
question, though. My question was.
But then the ones that were transferred, the roughly 15 to 17%, they were transferred.
What I'm asking for,
Yeah.
really specific, please, if you could address that, is we're just wondering, the couple hundred children between 2 and 6 in the morning were taken out of the facility the last day. That's odd, right?
No, it would not be odd, sir, for this reason.
It's not odd.
It's not
Interesting.
for this reason. If we're going to transfer them to another shelter, which is what we did for medical reasons or because they had no identifiable sponsor in the U.S., we would rely on commercial transportation at times, and that might involve an early morning flight if you're traveling.
So that was what happened, the final
transcontinental.
200?
That is, again, I don't know every single specifics, but I can guarantee that is most likely what happened. A lot of times, our staff will escort these children on very early morning flights.
And is
so that they arrive at a more
Sure, just because I got 30 seconds. Is Homestead completely empty of children right now?
It is, as of August 3rd.
And what are we spending to keep it empty at this point?
I don't know the exact number, but I do know that we reduced the support capacity from the 2,700 down to just 1,200, and so a lot of the staff were let go.
So are we paying equivalent of 1,200 kids a day to be there, or are we just paying a maintenance? Just trying to get an understanding of what we're spending.
It's a fully active shelter at this time with the ability to take.
So we're spending $750 a day on 1,200 imaginary people?
It's not 750, but yes, sir, we are.
What is the total then, just so I get
I
it?
think it's about 600.
$600 a day
We are.
for 1,200 invisible, imaginary, non-existent human beings at Homestead right
Well,
now,
it's the
every
beds.
single day.
It's the beds, but yes, sir, to keep them.
But why 1,200 if we have no one there? Couldn't we say 100 people that aren't there?
100 kids or?
Imaginary people. There's imaginary people there right now. There's no one there, but you're
Right.
spending, again, I have to explain back home, even $600 a day, you're still at the Four Seasons or the Trump Hotel, why we're spending that much, but now not to even have a child not getting mental health care. This is not to even have anyone stay there.
Congressman, I think one thing you and I can agree on is that this is a very expensive program to operate. If that's the point you're trying to make, I would agree with that. I will just state that if we remove the staff at Homestead, what I was told by my planning and logistics team and the senior career professionals at ORR, you're looking at a minimum of 90 to 120 days in order to reactivate the staff back for that. And again, given the extreme uncertainty of referrals coming across our nation's southern border and how many kids we might have to care for, that wasn't really a switch that we're ready to turn off at this point.
But some of that referrals is caused by the president's policies. I just add, my time is out, so I'm sorry. Thank you.
Yeah, thank you, sir.
Congresswoman Bustos.
Thank you, Chairwoman DeLauro, and thanks for holding this hearing and for the points that you've made. Thanks to the Office of Inspector General for taking a look at this. You know, the three of us were having these little side conversations up here. Congresswoman Frankel to my left, who has a grandson who's less than a year old. Congresswoman Watson Coleman, who has a grandson who's 6 years old, a granddaughter who's 6 years old. I've got 2 grandkids myself, and we are all just up here listening to these words: hopelessness, feelings of abandonment, fear, severe trauma. And we're all picturing our own grandchildren being in these situations, and we are just heartbroken. And when we look at this report, and every page we turn, just heartbreaking. And I don't care who is in the White House. I don't care if it's a Democrat or Republican. And I don't care who's sitting up here, whether we're Democrats or Republican. This is just heartbreaking to listen to this. Commander White, I was looking at your bio. You're a PhD, licensed clinical social worker, a career officer with the U.S. Public Health Service. Have you gone to these facilities and seen what's going on there? And I want to get like this. And have you also, Ms. Maxwell, have you seen this up close and personal?
Congresswoman, I was the senior career official over the UAC program previously, and prior to that, going back to 2012, I've been the emergency management official used in every one of the influx crises. I know these programs and their services pretty well from firsthand. I've also been in 2014 in the border stations, and I know what it is when we don't have bed capacity available for children in time. And that is the other part of the story that's also very important when we talk about beds not being used. And yes, I have seen these programs and know them well. Yes, ma'am.
So if maybe you could talk us through, you know, when it's not a visit that has been pre-planned, and as I think it was Congresswoman DeLauro was saying, that you walk in and you see smiling kids when this is a planned visit by members of Congress. What do you see? Tell us what you're seeing, and then my other follow-up question to that, because we get our full 5 minutes here, which is never enough time to have a decent conversation about all this. What are the long-term consequences of the kids who are living through the severe trauma, the angry feelings, the anxiousness? What are we going to see when these children are teenagers? And what are we going to see in our society as a result of what the government has done to these children?
So what you see when you're in a program on a regular day without members of the United States Congress there is not, in my experience, very different from what you see on a tour, except that the staff are much more nervous when there are members of Congress there. The children that you see and the environments in which you encounter them are what you would also see in domestic congregate child welfare settings licensed by the state, because that's what they are. The children, when you, as you talk to them and work with them, represent a range of experiences. Many of them have sustained extraordinary histories of trauma in home country, in transit, and in some cases in the United States. Separated children are intrinsically different, however, in that the traumas they have sustained are both extraordinarily severe and they are currently ongoing. And we are part of that traumatization in the United States government, which is different than being the response to that traumatization. Long term, the consequences of separation for many of these children will be lifelong. It will involve both behavioral and physical health harm, that all the best available evidence we have on trauma and toxic stress, including that focuses on children separated from their parents, would suggest will be both severe and very difficult to manage even with high levels of clinical care.
And all this could be prevented if the United States government in this administration didn't have these kind of policies that is allowing these children to go through this kind of trauma.
Separation other than for strict cause is preventable. However, Congress has not passed legislation of any kind to define the conditions under which separation may occur. And as I've asked previous committees, I will say again, that is a gap in law, and it is one that this Congress could, and I would submit should address.
Okay, I'm down to 3 seconds, so thank you for those answers. Appreciate it. I yield back.
Congresswoman Frankel.
Thank you. Okay. My little sponge here fell off. Okay. You can hear me? Okay. Thank you. Thank you all for being here, really. And, I really can tell from your expressions and what you're saying that all of you are very sincere about trying to correct a very terrible situation, which I know none of you really caused. But I just want to echo, before I ask my questions, what my colleague here, Ms. Busa, said, because I'm a new grandmother, and when I just think of what's the brutal, cruel policy of taking children from their parents, and to me, this is just government child abuse. It's child abuse. I want to start because I want to emphasize what Representative DeLauro has been talking about, which is the agreement with HHS, where HHS has agreed to share personal information of potential sponsors with agencies that can actually go to a home and perhaps seize an undocumented citizen. And I think what we experienced when we were at the Homestead, we all went to the Homestead facility, is that one of the feelings that we got is that one of the big reasons for the delay in getting these children back with with any member of the family, but was because of the fear that by giving a enforcement agency the ability to go to a home and then pick up an undocumented citizen. And so Mr. Hayes, I just want to know whether or not, what, if anything, are you doing about trying to get this agreement rescinded?
So I just would say one thing, actually, to correct Commander White. I don't believe the staff at the facility in your district was scared of you. I think they actually would look forward to you coming through the shelter, ma'am.
I agree.
Yep.
I agree.
They even had your picture up on the wall. So, I think one thing is clear. I think there's some confusion around the information that is shared. I think it's important. I noted this on the tour at Homestead. And as well at my last testimony here, is that going back to 2004, every time a UAC is discharged from ORR, they then go to the jurisdiction of the Department of Homeland Security, and that discharge notification form does go to DHS with the sponsor's information and the child, because it then falls on DHS and Department of Justice to keep them apprised of their court proceedings. So I just think that that's...
No, I understand that, but okay, so with that, because I have some more questions,
Yes,
but
ma'am.
here's the point we're trying to make,
Okay.
is that process is keeping children and families separated. Next question.
May I?
Wait, can I?
Yes, ma'am.
Well, I want to ask another question. There's a new policy, I understand, that the president has put in place that now prohibits people seeking asylum to come into the country, so they get stuck in Mexico. Is that correct? Is that going to affect the number of the undocumented children coming into the country?
I think the impact is unknown. There's a couple of things that are ongoing with some of the asylum laws, and again, HHS is not an immigration enforcement agency. I know we did issue a Dear Colleague letter where certain components of that we don't believe will impact the folks that are eligible to come into OR care, both on the refugee resettlement side and
They
the
have to come
UAC
into the
side.
country first, right? Is it going to be hard? It will be hard? I'm just, because the reason I ask this question, because Mr. Pocan asked about of spending a lot of money on invisible people. I'm just wondering, are you actually expecting more undocumented individuals to get in here, given the new policy?
Right. While I will acknowledge that the chairwoman is correct, our referral numbers are low, but if historical trends, and I would yield to Commander White here in a second as well, but if historical trends hold true, the expectation should be that as we move into these cooler months, there's a pretty significant chance that the referrals will increase, and most certainly as we get further into November and December, an even greater chance. Commander White? I don't know if-
I did just want to say this, and I'll keep this brief out of respect for you, ma'am. Every influx crisis in the history of this program, and in fairness, I have been deeply involved in response to all of them, so I have some experience to speak from. Every one of them was preceded by a period of reduced referral and pressure to reduce capacity or stop expanding capacity. And I have asked colleagues on the career side, on the appointed side, and I will now ask Congress, can we please not make this mistake again of thinking every time it goes down that that's like the future? This is an oscillating, highly volatile system, and the best way to keep children off the floors of border stations is to not react when there's a downturn and say, oh, look, that's the end of migration highs.
Let me just say 2 points that I guess, because I'm running out of time here, but one thing that we found on our visit is that children who were reaching the age, they were getting to an age where they were going to age out. Terrible stress on them, because that meant they were going to be incarcerated. And the second thing is, I think what we have to remember is that these children, once they are released or to a family or whatever, you know, a lot of damage has been done, and now they're out in our community. And my question is, is there follow-up? Do they get mental health services, or is that it?
Yep. So whenever a child is discharged, there's two separate questions, ma'am. So we do have children that do age out. Once you turn 18, the statutory authority at HHS ends inside the ORR UAC program. Our teams work very closely with the local ICE officials to come up with a post-18 plan. And as I said on the tour, if it were solely up to our grantees and the ORR career staff, the kids could stay with us till they were 22, but it's not our decision.
No, they're going to.
We do work very closely, and a lot of times they are released in that post-18 plan on their own recognizance. I would just add, as far as the second, what was the second question you asked?
What happens once they're released? They have this trauma.
Yep. So there is a 30-day follow-up call from our team, and if there are post-release services that are recommended by the team, again, we work with a particular project officer at ORR with approximately 11 grantees to identify post-release services that might be available within the community.
Thank you.
Congressman Watson-Cole. Yes.
Thank you very much. Thank you very much. Thank you for being here. And Madam Chair and Ranking Member, thank you for hosting us here in this very important committee meeting. Before I start asking my questions, I need to make a comment. There was a comment made up here by one of my colleagues, and it had to do with, I found very offensive, and what it suggested was that parents are making a choice to be separated from their children. And I just cannot believe that that is the truth in any way, shape, or form. I'm a grandmother, and I'm sitting up here listening to what these young children are going through. My granddaughter is 6 years old, and it breaks my heart. Not only does it break my heart for the child, it breaks my heart for the parent or the relative of that child. And I just think that we're moving in the wrong direction here. Do we or do we not have a no separation, family separation policy now? I'm going to ask you, Mr.
So,
is that a yes or a no?
yeah, so Based on my understanding, the president did issue an executive order stopping family separation as a result of the zero tolerance policy, specifically for an immigration violation. However, separations do continue for other reasons and have. Such as past criminal activity of the parent, legitimate child welfare concerns. There's a myriad of issues. We'd be happy to get you a list of the different categories that fit in that. But I think it's important to note that there's been separations in the entire history of this program.
So you were very successful in reducing the census at your facilities, extremely.
Yes, ma'am.
And I'd like to know specifically, what were some of the things that you did to facilitate that release? And are those things part of the ongoing policy now?
They are, ma'am. I issued 4 operational directives. The first one, about 3 weeks after I was named the acting director at the end of November. The first operational directive ended the household member fingerprint checks, which at the counsel of my senior career staff and child welfare experts did not deliver any new or additional information that would cause them to change the decision to discharge that child to his or her family member. The second operational directive was in March of this year, ma'am, and that was in regards to the moms and dads that are seeking to sponsor their children. We quit fingerprinting them as well, provided there was no red flag or hit on the public records check or sex offender registry check in that. The operational directive number 3 had to do with the immigration status checks. We suspended the reconciliation of the ICE background checks, results from our sponsors. We rely on the testimony and communication with each sponsor. Only thing we ask is that if a potential sponsor is undocumented and here without status and could potentially be deported, is there a safety plan, meaning who will the child go to if you are deported? And then the 4th operational directive was also done in June of this year, where we are still to this time, but it is a temporary action. We are treating the grandparents and adult siblings the same way we would moms and dads, meaning if they're seeking to sponsor the family member and there are no hits or red flags on the public records check or the sex offender registry checks, we do not do the FBI fingerprint checks, which does take additional time.
So
And I'll just add, I visited over 50 of our shelters, and that was one of the recommendations that came from the field that I brought back and discussed with the team, and we implemented.
So during that period of time where you were able to facilitate those releases more quickly, did they suspend looking at everyone that lived in the household, determining what their status was?
We still do the public records check, but again, at
What's
the end
that
of the
mean?
day, it's just like a looks at both the federal, the state, law enforcement type background to see if there's any hits or red flags or anything to give us any concern. I will point out that at the end of the day, it's about the integrity of the sponsor.
Yeah, I agree.
They can only share with us who's in the house, and they can move the next week. So that's where I want my
So,
team to focus is on the sponsor.
So, I know you're not the cause of these policies. You're the recipient of these policies. So this memorandum of agreement or understanding really doesn't need to exist. And do you have the authority, or does your department have the authority to withdraw from that agreement? And if so, why haven't you?
I do not have the authority myself. I'm not going to speak for the Department of Health and Human Services.
But you're the frontline person. Do you agree that we can function without that?
So
That we had the safeguards in place that were used to facilitate the release of those children?
Yeah, I would just say I think the actions I've taken since becoming acting director and director speak to my overall belief of the majority of the MOA. I just will flag, though, that that there is referral information learned by DHS after the child comes into our care. It kind of memorializes also the abuse reporting to DHS when we learn about it. So there are some things left in the MOA, but in regards to processing the children.
And Ms. Maxwell, do you agree that this MOA could be suspended?
We recommend that OR do as it's continuing to do, which is to assess all of their current policies to make sure there are no unintended consequences for releasing children. So we would recommend a continued reassessment.
Thank you. I yield back. Thank you, ma'am.
Congresswoman Lee.
Thank you very much, Madam Chairman. Thank you and our ranking member for this hearing. And it's a very troubling hearing for me personally and as an elected official. First of all, I have to remind you, and in making the statement, I want to be very clear that we recognize that this is the 400 year since the first enslaved Africans were brought to America. One of the basic elements of the United States policy was to take children from their families. That was family separation. This has had generational impact. We're still addressing it and dealing with the trauma today. This is yet another stain on our country. And I'm not personalizing it toward any of you because I know what you're feeling and what you're seeing. But I want to put this in context so we understand what is taking place. This policy did not just start. I am very concerned that a lot of the recommendations that the American Psychiatric Association, and I want to read some of their testimony to this committee, and also the National or American Society of Pediatrics, I'm not sure if that's the correct name of their group, but I want to explain a couple of recommendations they made. First of all, they said that we needed an independent medical and mental health monitoring team, totally independent from the government. Secondly, the Psychiatric Association, let me just read you a couple of paragraphs from their statement. We know that children are more susceptible to trauma because their brain is still developing. When a person is exposed to a traumatic event, the brain naturally enters a heightened state of stress and fear-related hormones are released. And although stress is a common element of life, when a child is exposed to chronic trauma or extreme stress, their underdeveloped brain will remain in this elevated state. Ultimately, consistent exposure to this heightened stress or trauma can change the emotional, behavioral, and cognitive functioning of the child in order to promote survival. Psychiatrists are most qualified to help children and families recover from the trauma inflicted upon immigrants and refugees by displacement from and within their home countries and can provide direct psychotherapeutic and psychosocial intervention. Each staff and their leadership teams should really address the appropriate care, suffering, and identify this as post-traumatic symptoms and other migration-related symptoms of distress. And then they go on to explain one more thing I'd like to read from their testimony. Detention of innocent children should never occur in a civilized society, especially if there are less restrictive options, because the risk of harm to children simply cannot be justified. Now, I want to find out from you what in the world happens to these children after this damage has been done by the policies that this government has put in place in terms of trauma-informed mental health care. I recognize that mental health care I'm a psychiatric social by profession. There are a variety of treatment modalities, but these children require specific trauma-related treatment, and it's not 1, 2, 3, 4, 5, 6, 7 sessions. This is years of treatment they're going to need. So how are you going to do this, and what type of resources? And have you met with and talked with the professionals on the outside who could probably give you a lot of help in what you're doing?
Thank you, Congresswoman. I would just point out that and again, thank you again for the for the supplemental funding that y'all provided. I know a part of that was not less than $100 million to increase both legal services, post-release services, and child advocates. And that's something that we are working on with our grantees. We've recently sent out a request for proposal to expand those post-release services available to the children, especially those that need long-term mental health care and behavioral health issues as they leave ORR care.
But are you specifically saying trauma-related care related to PTSD?
I don't know how specific we're getting. It's a broad array of post-release services. It could be medical care, legal services.
I understand that, but I'm focusing on the mental health care right now in terms of the appropriate types of mental health treatment modalities that you're going to use to make sure that these kids don't end up, when they're adults, not very happy with our own country.
Right. Want to speak to that, sir?
Ma'am, that is a focus of the efforts, and as you know, among the challenges are the delivery of appropriately intensive psychotherapeutic services during the duration of time that children are in care. So the answer to your question is absolutely. One of the key focuses for the current efforts to further strengthen our ability to deliver appropriate trauma-informed services to the children in our care is to work with experts, including NCTSN, to identify what are the best evidence-based methods to respond to the very high, both the high ACEs scores, the history of toxic stress, and the traumatic exposures that children have during the window of time that we have and with the resource picture we have. So the answer to your question, Congressman, is absolutely.
Congresswoman Clark.
My time, oh, time's up.
Thank you, Madam Chairwoman. Thank you all. We appreciate you coming back and for our new arrivals, your testimony here today. It's hard to know where to start. As Commander, as you said in response to some previous questions, the only real way to address this level of trauma in children is prevention. And we know that many of these children are coming to this country already experiencing great trauma, where they lived at home, in transit, but we have added to this. And I want to reiterate what my colleague, Congresswoman Lee, said. We know that you are trying to do jobs in a tough and changing situation, but I think you have to understand how it looks from our vantage point, that children are being used in this immigration policy, and the harm that we are inflicting on them and on these families may be irreparable, and that we have a role in that as the U.S. government. And what troubles me deeply about Homestead is that this is a private contract with Caliburn International, where Secretary John Kelly sits on the board. And they wrote in their filings for the SEC as they announced plans to go public, border enforcement and immigration policy is driving significant growth for our company. Significant growth. At what cost to the human experience and to this stain on our country and the way we are treating these immigrant children? And to hear that we continue to pay, and I understand very clearly that we need to understand that that migrant patterns are patterns, and they go up and down, and we want to be ready. But there are other programs out there that exist, like the case management that I understand is, an Homeland Security program, not under your purview, but it works. And it has great compliance with families getting to court, to making sure their asylum cases are heard, have a fair decision. And what does it cost? It costs $36 a day. These are the type of programs that I would think that when we are experiencing a decline in population, why aren't we looking at those type of programs that get kids out of detention and with their families and have compliance? Why aren't we looking at increasing our nonprofits that can save money instead of continuing to operate Homestead empty at almost double the rate of what we pay some other agencies to take care of children? These are big questions, but if you could give me some direction, Mr. Hayes, I would appreciate it.
Yes, ma'am, Congresswoman. So I think I just would point out that, again, the Homestead site and the operator was chosen back in late 2015, long before General John Kelly joined any of the companies that you mentioned. Yes, we did renew that contract with them. I would just say that, again, I want to reiterate my statements earlier. I am absolutely committed to, as is Assistant Secretary Johnson and Secretary Azar, to having as many state-licensed permanent network beds as possible to receive these children, and we're working to that end. But the challenge that we have, Congresswoman, is that at the end of the day, the final say in those facilities being licensed and receiving children does not lie with the federal government. It requires a partnership with the states and the local communities. And we are, as again, starting to see some resistance to that, and that's very unfortunate. I would respectfully request this committee to help out and help us as one of the stakeholders in this process of caring for these children, help us achieve that goal of expanding the type of shelters that we have in Ms. Frankel's district that her and I went through. It's about 140 beds for teenage girls and it's a wonderful facility. That's what we want, and we're working towards that. But to Commander White's point, when we see huge influxes of children coming across the border and the need to be able to secure them, we have to be able to, have those beds available. And if we're having
Mr.
challenges.
Hayes, are you working at all to redefine what we mean by family members? When I was at Homestead, we heard many stories of children coming across the border with grandparents
Yes.
who did not qualify and made these children unaccompanied minors. If we're trying to reduce trauma to children, if we're trying to keep children out of detention beds, not be separated, are you working actively to say, why don't we include aunts and uncles and grandparents in a definition of family that is rational?
So that is not my decision. That authority lies with Congress, and I know that the senior staff that I speak to would absolutely support some modifications to the Trafficking Victim Protection Reauthorization and the Homeland Security Act that drives that.
The definition of children who cross the border with a loving grandparent, with abuelita, with an older brother who's over 18, to define those children as unaccompanied is a black letter law issue. Congress absolutely has the power to make that change if you wish, but neither DHS nor HHS has any legal authority to consider a child who crossed, even with a loving grandparent, even with a loving older sister, as anyone other than unaccompanied. That's not our call.
Right.
It's not your call, but would you support that change?
I would support that change.
Would you, Mr. Hayes?
I would as well, and I've heard it from a number of my staff. And I just want to point, I believe that's what is at the heart of my fourth operational directive in late June, where we are at this time when it comes to the background check process of the sponsored discharge package. We are treating grandparents and adult siblings the same way we would moms and dads, because as a father of 5, I completely agree. I want these kids with family members as they wait for their court proceedings to go forward. Anything I can do to make that faster while it's still holding up an acceptable level of safety, I will do that in conjunction with collaboration of my team.
Thank you.
Yes, ma'am.
You can be sure that we will address that issue and that there will be legislation as quickly as possible. And I'm hopeful that my colleagues on both sides of the aisle would be in agreement, since you are all in support of it. The other piece is I might add that Assistant Secretary Johnson, at our hearing, who, with all due respect, Mr. Hayes, is, I think, your boss, if you will,
Yes,
that
ma'am, she
she
is.
said that we should rescind the memorandum of agreement. So I'm hoping that we can, or that the Assistant Secretary will be listened to by the administration of doing that. That's why you put good, solid, bright people like the people who are here this morning, who understand these issues and make recommendations about what we should do. I'm going to get to my questions, but I've got to say the issue is discharge, discharge, discharge. Our focus is always on holding the influx facility, and the numbers are going down. Yes, they can go up. However, with a change in one directive in 2018 in December, we went from, and you pointed out that I was inaccurate. I said overnight, 15,000 kids. We let 4,000 out. You told me, Mr. Hayes, it was 8,000. So if we can move kids that fast, we do not have to have them sleeping on the floor at a DHS facility, which is, no one wants them to do that. But we were able to move, we moved quickly, and we're now down to, as I understand it, some 5,800 kids. We did not have to have a backlog. We did not. That was created. And you got the $2.9 billion, and now you're less engaged in dealing with $750 a night for a facility, which was the reason why we had to build the capacity, build the capacity, build the capacity. And what we need to do now, and I want to see that plan in October, of how we move kids out as fast as we can to a safe placement as expeditiously as possible. That is your goal. I don't speak for DHS. I don't know what their goals are. But that is HHS, which is under the jurisdiction of this committee. Mr. Hayes, you talked about the webinar series, okay? And I'm proud and excited, and the ranking member understands this. National Child Traumatic Stress Network, I will be self-serving for the moment. I was the first member of Congress to put funding into that system because I understood what it did as my understanding of it through the Yale Child Study Program in New Haven, Connecticut. And we helped to craft that and provide money for it. So we have done that. I'm glad you're there. You've talked about, I want to hear about the direct services. You've talked, other than the webinar a series, what have you done to increase access of child trauma experts to children in HHS facilities while children are in ORR care and in the post-release situations? As I said, you got $2.9 billion. Numbers are down. We don't have to pay the $750 a night. How are we rearranging those dollars to assist in this process? We're paying $600 a night. Yeah, so $750 to $600. $150 a night, that's real money. I believe that.
It is, yes,
But,
ma'am.
Yeah.
And I just
Talk
want
to me about direct services.
And I just want to point out for the record, too, none of our grantees makes the decision on any child going to their shelter. That decision is made by federal staff on the intakes team at ORR. So I don't just make sure that people understand that that whether it be Homestead or whether it be a BCFS facility in the Rio Grande Valley, that is not a decision that any of the grantees make. Federal staff provide oversight and make the decisions on where the children go. In regards to the children that are in our care, Madam Chair, I just would again point to to the OIG's report and to the council.
What direct services besides a webinar are you going to, please? Because they're going to kill me.
I understand.
Jason.
Again,
Going overtime.
given the very short time that these children are in our care, the focus of the clinical work of our team is to focus on both providing a safe and secure environment and stabilizing the child. Again, that's right out of the OIG report. And the report that you showed the length of care is significantly dropping. And I do know that I always want to be the type of director that listens to the counsel of our medical team, and I've heard it firsthand out in the field and also here in D.C. that there is a hesitation to really get into some of the deeper trauma, given the fact they don't know how long they're going to be in our care.
But, you need to deal with direct services. Are you going to take any of this money from the $2.9 billion and provide it there? Because you say you're going to add your own funds to what is going on at the NCTSN.
We will continue to seek ways to properly invest that money in the care of the children. Yes, ma'am.
Okay, look, I will come back to additional questions.
Thank you very much. Point I want to make, and then a couple of questions to ask. The point is, and you were, I think, there, Director Hayes, we were down along the border. There's a lot of manipulation of these unaccompanied minors by people coming into the country. We were told that only 1% of adult males in 2015 that were coming across that border had an unaccompanied child with them, and it was 50% now. So it's clearly, some of these kids are being used by adults that think it enhances their chances of getting in the country and being able to stay. I don't know how you deal with that, but it's something we ought to recognize that they're having to confront down there. It was very interesting to see, and again, the money Congress voted gave them the capability. They were doing DNA tests on selected individuals just to see if the people were related. About 1 out of 3 of the people they tested were not related in the manner described. So this is, these children have been used literally in these kinds of cases by people trying to get into the country illegally and by cartels, and that's just a fact. And you're confronted, and we asked you to deal with it, and you don't do the apprehensions. You're just, you're dealing with the kids that we turn over to you. Question I have, and there's a tension here, and I know we're all trying to get to the right point, but a tension between getting them placed as quickly as possible and giving them the best care that we can give them after a very traumatic experience, because you don't have them there, as the commander pointed out, very long, and as you've pointed out. So could you describe a little bit how you handle that dilemma, and what, in what ways, if any, does the care follow the child? Or you might not even have had time to actually assess the full needs of the child in the amount of time that you have them there. So this is a real problem area, I think.
Thank you, Congressman. To your point, I know of a recent example where a child was in our care for 3 or 4 days before she was discharged to her mother. It was not a separation. And so, if there is circumstances surrounding, what happened back in home country, the journey, and then coming into our care, I mean, she was only with our shelter for maybe 3.5 days before where I think is a more appropriate environment, she moved to with her mom. So, that is a question that, that I would not seek to answer. I'm not a mental health clinician, but again, I receive counsel from a large number of them, and their focus, again, not knowing exactly how long the children are going to be in our care, they focus on stabilizing the child and making sure that the child feels secure. Because I think to a point earlier, they do view, initially at least, all of us as kind of the same bucket in regards to the U.S. government. But we see that as they spend more time in an HHS shelter, and it's like not in detention, and they're surrounded by medical professionals and clinicians and youth care workers and other kids, their comfort level and their confidence in our team does absolutely increase, and we learn more about the child and his or her journey and their history, and as that stuff is told to them, then that is incorporated into the clinical work that our team does. But again, to the OIG report's point, it is tough when you really don't know how long you're going to have that child, and the licensed mental health professionals tell us that there is a hesitation to want to try to get into that too deep if they might be gone within a week or two.
Yeah, Commander, if I could, I'd like your thoughts on this, in terms of, again, we obviously want to place them as quickly as we can in an appropriate environment. How do we make sure, and again, these kids have been traumatized before they get here in many cases, either by conditions at home or the journey. What are your thoughts on how we make sure that while we're placing them rapidly, we can both diagnose the problem and see if there's something that we can do about it? I mean, they move out of HHS's care pretty rapidly, and that's got to be a challenge in this area.
Yes, sir. There are 3 things we have to do, and I want to be really clear, both as a person who's managed this program and as a clinician. They're hard. They're hard, but they're necessary. The first thing we have to do is we have to build every one of our programs from a trauma-informed lens, so that not just the minute that the child is sitting with his or her clinician, but every moment that they're in the program, we're doing what we can to mitigate the traumatic experiences they've sustained, as well as the distress of the time that they spend spend in congregate care. The second thing that we have to do is we have to provide both individual and group modality psychotherapeutic interventions to every child. These are not a random cross-section of children. The life experiences of children, particularly for the more than 90% of the children in the OR program who come from the northern triangle of Central America, these are children literally coming from the worst places on earth to be a child, where the vast majority of these children have observed homicides, have experienced personal traumatic loss, have been victimized themselves through physical assaults and sexual assaults. That is not uncommon in this program, that is the norm. So the second is we need to have those methods in place, recognizing all of the incredible challenges to doing that. And the third is that we need to continue to work, as we do, with sponsors to identify the resources that they can access individually in the communities where they live to provide continuing care for the children. I want to be really clear, all of these things are incredibly hard, and that's why the guidance from OIG matters. We are not failing at an easy thing. We are continuing to struggle at an incredibly difficult thing, and I'm very proud of what my colleagues in ORR do every day on this problem.
Thank you very much. Thank you, Madam Chair.
Follow up quickly on something that Congressman Cole said, which is, and I think you've made reference to it, Commander, is the post-release services. And we know, I think we all know, that there is a serious backlog and that there are children on this wait list. Thousands of kids flagged to receive services waiting weeks or months before they receive the kinds of services. So now I'm going to yield to Congresswoman Roybal Allard, but if we come back again, I really would like to pursue post-release services and that backlog. Congresswoman Roybal Allard.
Before I ask my question, I am a little concerned, as was Ms. Watson, that an impression may have been left that somehow parents are just sending their kids here, picking and choosing and sending their kids here. And, you know, we have heard from the immigrants that we have spoken to as to the various reasons, which we've all heard, rape, gang, and so forth. I was on a trip to the Northern Triangle with Speaker Pelosi, and the reason we went there was to hear from our own government agencies, the NGOs, USAID, the Coast Guard, CBP, the agencies that are there on the ground as to what their thinking was and the reasons why so many young people and parents were coming to the United States. And they validated everything that we had been told by the immigrants themselves as to why they were coming. In fact, in some cases, what we learned was even more horrific. For example, USAID was saying, and some of the other agencies were saying, that they were now focusing on the 8 to 12-year-old kids and using the money or the foreign aid that we're sending there to focus on the 8 to 12-year-old kids, because that's where the gangs were focused, on recruiting the 8 to 12. And if these kids didn't join, they would then threaten them with killing their parents or a sibling. And to be part of that gang, the 8 to 12-year-olds had to kill 5 people. That was the price. That is why parents are sending their children here. Also, when I went to Texas with Congresswoman Escobar, we crossed over to where there were one of the shelters on the Mexican side, and there was about 80 or more immigrants there from different countries. The Congresswoman asked them why they were there. We heard similar things, including the fact that they could no longer grow crops in their country, and they were hungry. They couldn't feed their families and were coming to the United States. She then asked them, if you could provide for your family, and if you could feel safe in your country, how many of you would still want to come to the United States? Not one person raised their hand. They said, no, we love our country, we want to be in our country. We're here because we had no choice. So I just want to make it clear that parents are just not deciding for the heck of it to send their kids to the United States. Ms. Maxwell, according to your report, even mental health clinicians with prior experience in this field felt unprepared to handle the level of trauma that these children had experienced. If the trained mental health providers felt unprepared, I would assume that ORR caretaking staff must be completely overwhelmed when faced with when the needs of these children. And I understand that your investigators spoke with the mental health and physical health clinicians during the investigation. But did you speak, or your investigators speak directly with the caretaking staff about their training on how to meet the mental health needs of these fairly traumatized children who were under their care?
Thank you for that question. We have a broad body of work that we are undertaking, and we asked a whole host of questions. We did talk to the youth care workers. That is for a future study that's coming out later this fall. In this particular study, we focused only on the mental health clinicians.
So do you know when that study will be coming out?
As soon as we can get it through our very rigorous quality control process, we will have it in your hands.
Do I have time for one more? Okay. According to the Flores Settlement Agreement, each child in ORR custody should have a comprehensive and individualized plan for care. Did your investigators check to see if there were care plans in place for these sexually traumatized children?
Not in this particular study. We have an ongoing series of audits that looks at 8 grantees over 6 different states. And in those particular audits, we did look at whether or not grantees were compliant with rules and regulations. And one of the regulations we looked at was whether they had care plans. In some cases, we did find documentation missing in children's files.
Okay, so a lot of the issues that we're bringing up then will be in subsequent studies, am I?
The audits that I'm talking about, a number of them are already public. I'm be happy to share them with you so you could see specifically what's happening at various grantees. The study I was referring to looks at the safety in the facilities, and that'll be coming out later this fall.
Okay, thank you. I see
Thank
my
you.
time's up.
Congressman Harris.
Thank you very much, Madam Chair. And let me just clear it up for the Congress ladies who had a question about it. I just reiterated, I think, Mr. Hayes, that you said the vast majority of children you're taking care of now are UACs, not people separated by legal policy. Is that correct?
That is
one
correct.
Okay, so to say that the Trump administration is somehow responsible because of the pitiful conditions in the Northern Triangle that make a parent choose to separate themselves from their child is not this Trump administration, neither is the Obama administration or any of our policies. It's a problem in those home countries. The Northern Triangle, let's talk a little about Northern Triangle. Let's get back to Baltimore or Detroit and New Orleans, all of which have a murder rate that's higher than Guatemala. Baltimore's is on level with Honduras. El Salvador does take the cake, all right? They're higher. So again, I would just offer that we have a public health issue in this country with taking care of the mental health of children who are exposed in the failure to control the murder rates in large American cities that certainly the Trump administration doesn't control. All right, let's talk a little about the fingerprinting. Under your policy, do you fingerprint fewer people or more categories of people than the Obama administration fingerprinted when they released? My understanding, for instance, is you don't fingerprint grandparents
Right.
who have taken care of children when the Obama administration did fingerprint
At
grandparents.
this moment, we are fingerprinting less because we're not doing grandparents and adult siblings.
Less. Well, that's interesting because I certainly didn't hear that as a compliment from anyone saying, oh, by the way, congratulations, you're actually doing less fingerprinting, therefore resulting in less fear of family unification than under the last administration. So I thank you for doing that, okay? No question about it. Now let me just get to the crux of how separation occurs. Because if you are a parent with your child, you're a single mother with your child, and you go to a port of entry and go through the legal process of filing for asylum, you don't end up in ORR, the child doesn't end up in ORR custody unless there's some question about the ability of the qualifications of that parent to be an adequate parent, either not a criminal, et cetera. Is that right? You're only taking care of children whose parents broke the law. Right? Because you don't break the law. If you request asylum in a port of entry, you don't break the law, there's no question of separation unless, of course, you're a criminal yourself, the parent's a criminal. Is that correct? The children in your custody, in fact, are not children whose parents have followed the asylum law of the United States by entering through a port of entry.
I think I just want to clarify, Congressman, that the majority of children in the care of HHS did not come across the border with a mom or a dad.
Yeah, I fully get that. But now I'm talking about whether this administration is responsible for the parent breaking the law and not following, because my point is, if the parent followed the law, and we know the vast majority request asylum, that's not your bailiwick, but the vast majority of people crossing the border now request asylum. If they request asylum at a port of entry following our asylum law, there is no question of automatic separation. There never was. Is that right? And again, maybe I should be asking DHS.
Unfortunately, Congressman, among the separated children in the Mizell class, including the named plaintiff, there are children whose parents presented at a U.S. port of entry. Nonetheless, I think the take-home is that the vast majority of children in the care of ORR are truly unaccompanied, not separated children.
That's correct. And in fact, their parents broke the law. So one solution, prophylactic solution, I guess would be to enforce border law. Maybe if we actually enforce the law, we would not allow people to enter illegally with their children, which has resulted in separation. I'm not going to judge, but is that more or less correct? I mean, we really are, and I'm going to have to look at those cases, because my understanding of the law is if you enter, you are legally present in the United States if you enter at a port of entry requesting asylum. So doing everything you need to do at a port of entry. So, but I'll check on that. Again, if we just enforce border law, we wouldn't need to have separations. We don't need to have, we probably don't need to have it anyway, but we certainly wouldn't need it if all we did is enforce border law. I suggest maybe we just do one of the simple things and maybe just agree with the president that the border ought to be enforced. We shouldn't have an open border. I yield back.
Congresswoman Lee. Go for it, Barbara.
Let me ask a question. Just to clarify, who has the authority, well, in terms of the MOU and its rescission, who has the authority to sign for the rescission and who signed it initially?
I do know that the former director of ORR signed it, as well as the acting director, the acting assistant secretary of children and families. I'm honestly not sure at DHS who signed it, ma'am. I have read it, but I can't remember specifically. So
And
I would
who
not
can
want to
rescind it? Who has the authority to rescind it?
I would assume the agencies that all signed it, definitely above my pay grade, but.
Well,
I
okay,
don't
would it
have-
be
I
the
don't know answer to
secretary
that,
of
ma'am. I'm sorry.
HHS? Maybe?
No, it was
Or-
it was at the assistant secretary level.
Assistant
I can without a doubt
Okay.
say that the former director of ORR and the former acting assistant secretary of children and families inside HHS were two of the signatories. I cannot remember who signed it from
Okay,
from
does
DHS.
anyone know, Ms. Maxwell, does anyone know who has the authority to rescind this?
No, I do
No.
not know that.
Could you get back to us in writing, who has the authority to rescind the MOU?
I'll be happy to work with our assistant secretary of financial resources and a team at HHS
Yeah.
and get that answer back.
Okay, thank you. Let me ask you another question with regard to the children and the treatment. First of all, policies that have been created by this administration have very serious future potential problems if not dealt with properly as it relates to the appropriate type of mental health services. I want to read to you again this is from the National Child Traumatic Stress Network, which gives us a glimpse of what could happen if in fact these children aren't treated properly. They said, complexly traumatized children are more likely to engage in high-risk behaviors such as self-harm, unsafe sexual practices, and excessive risk-taking, such as operating a vehicle at high speeds. They may also engage in illegal activities, such as alcohol and substance abuse, assaulting others, stealing, running away, and/or prostitution, thereby making it more likely that they will enter the juvenile justice system. Now, this characterization really does outline the high stakes associated with proactively mitigating the impacts of childhood trauma. So I think, and I'm wondering, Commander White, have you all thought this through all the way out? Because I foresee some very difficult issues that these children are going to face as a result of the trauma that they have experienced and not treating them properly, just in terms of some of these issues, but also in terms of other public safety, national security issues. I mean, how do you think someone's going to feel at 18 years old that they were taken from their parents and then they were treated in a way that wasn't healthy and that did not help restore their mental health as a result of PTSD?
So Congresswoman, all of the outcomes that you describe are well supported by the evidence and the science for children who've sustained prolonged and complex traumatic experiences. This has long been part of the planning within ORR for the care of unaccompanied children. As I said before, separated children pose a unique problem, one that I think the program is not designed to respond to. But the one caveat that I would say in the list of outcomes you said is that the best evidence that we have would suggest that the children in our program are at lower risk of committing serious crimes than children in the domestic child welfare environment. And given that sometimes they have been characterized publicly as a high crime risk, I want to clarify that record.
And I'm not saying they are now. I'm talking about long-term, if you don't treat traumatized children with the appropriate psychotherapy, long-term care.
We agree, ma'am, and this is part of the longstanding and evolving process of planning for the mental health needs of the very specific population of unaccompanied children who enter the country without parents, often fleeing poverty and violence, which is the population we serve. Yes, ma'am.
With children separated from their parents, you have that added element of anger.
Yes, ma'am. As
So
I've
how do you address anger management, and how do they work through that anger in the type of treatment that you're proposing?
So fundamentally, as I said before, I do not believe the UAC program is designed or capable of meeting the behavioral health needs of separated children. The only way to prevent that harm is to prevent
Yeah, but
the
you've got
separation.
children now you've got to address.
Correct.
So we've got to figure this out, and I believe that some outside mental health organizations, such as the American Psychiatric Association, such as the National Child Trauma Stress Network, such as the pediatricians, I think you need some help with this.
Many of those partnerships are underway. I just want to speak to the reality that separation cannot be managed with a tertiary intervention strategy, only by preventing separation.
I understand that. I started my comment earlier by African Americans, the policy of separation of children 400 years ago. It
Yes, ma'am.
has
The historical
generational
verdict
impact.
on family separation is in.
It's in. And so hopefully you will have learned from this, and hopefully, I don't want to hear saying we can't do anything, or that this is a population of children that we just don't have a approach or a solution to, because if not, you're going to have thousands of children with this long-term trauma that's going to be transmitted to their children through DNA changes.
Yes, ma'am. If that's how I came across, that was not my intention. The reality is most of the separated children were discharged under an expedited court-ordered reunification process. But the fundamental reality is while we continue to work on best efforts to respond to their needs, we cannot plan for future separations. Instead, it is the job of everyone, including Congress, to prevent them.
Congresswoman Clark.
Thank you, Madam Chairwoman. First, I just want to assure our witnesses that us Congress ladies do understand the complex social and economic factors in the Northern Triangle that impact immigration into this country. And we also understand that threats to withdraw aid from those countries do not help, that policies like Remain in Mexico do not help and make your jobs trying to meet the needs of these children and families and deal with the trauma they have suffered in their long-term mental health even more difficult. Director Hayes, back when you were here on July 1st, we talked about providing this subcommittee with additional information on sexual assaults. I wondered if you could give me an updated timeline for the release of the prevention of sexual abuse reports, and if you have any preview for the subcommittee on some of those findings and how they may impact change in ORR policies.
So I believe those reports have been posted. If they have not, they will in the very near future. And I will definitely go back and check with the team and work through the Assistant Secretary for Financial Resources and her team to communicate that back to you. What was the second question, ma'am?
Well, if you could give us a preview of any of those reports and any proposed change in policies you might be proposing in response.
Well, I would just say that, we have, late end of last year, we did hire the Prevention of Sexual Abuse Coordinator, and that is a team that we are building and seek to further build at ORR, and will continue to remain engaged according with applicable laws and ORR policies and procedures.
Okay.
Yes, ma'am.
Ms. Maxwell, the OIG also recently released a report on ORR's facilities' adherence to background checks. I wonder if you could tell me, are there any gaps that facilities faced in conducting those appropriate background checks?
Thank you. That's correct. We did release that report in conjunction with this report and found that generally speaking, facilities were adhering to the required background check screenings necessary to protect children. We did find some gaps, though, as you mentioned, and in particular, one of the areas we found that over half the facilities were allowing clinicians to work with children prior to the results of the background check being submitted to the facility. We did alert OR immediately about that fact, and OR has taken action, putting out information and reminding facilities that clinicians should not be allowed to work with children until the background check results are in. We also had some concerns about waivers for the CAN checks, and again, that issue has been addressed by ORR. So we have other recommendations out there, but we continue to work with the administration to make sure that all the background checks are in place.
Great. Do you have anything to add, Director Hayes, into how you are addressing these issues in background checks?
No, I just would add, Chairwoman DeLauro, Congresswoman Clark, I think it was on the tour that y'all both were on, but in regards to some potential changes to TVPRA and HSA, one of your colleagues also talked about aunts and uncles maybe being in that category as well. So when y'all have that discussion, I would just encourage you to consider that as well as maybe being potentially close family in a lot of these situations and families.
All right, thank you. I yield back.
Thank you. Let me now yield to the ranking member, Congressman Cole, for any further comments or questions.
Thank you very much. I'll try and be brief, Madam Chair, but I want to end where I began. I want to thank you for the hearing and your focus on this issue. And we have a lot of pretty fierce debates about immigration, what's appropriate, what's not appropriate. But I think we all agree that any child that comes into the custody of the government of the United States needs to be taken care of and well treated. And I think we've come short in some cases, but I think you've pushed us in the right direction, and you ought to be proud of that. I'm proud of you for doing it. Second, I want to thank you, Madam Inspector General Maxwell. I know you're an assistant, but we're going to elevate you today because I just think you've done a great job here. I think this is a great service, and it's exactly what we asked Inspector Generals to do, to go and provide us with the information we need to make appropriate decision. I want to thank you too, Director Hayes, again, and Commander. Had the opportunity to visit with the border with you. I think things have gotten measurably better during your tenure. I don't have any doubt about your dedication to try and take the information that Ms. Maxwell has given you and respond appropriately within the limits of your resources. And fortunately, Congress expanded those resources in July, something we need to think about going forward. We were overtaken by this crisis in 2014. We're reliving this, and I'm not sure that we prepared very well in between for this happening to us again. I mean, again, I don't have any magic solutions for what's going on in the Northern Triangle countries, but I suspect this won't be the last surge that we see. So being a little bit better prepared and recognizing this may come again and institutionalizing some of these things, I think, is important as we go forward. I know you're dealing with the challenge you have now, but at a future time, I would welcome your thoughts, and I know you guys are thinking about this, as to what we need to do to make sure that if we have a situation like this, we're a little bit better prepared to deal with it than I think we were this particular time. So with that, again, I think this is a little case study in how Congress ought to work. It's a real oversight. It's good information from the executive branch to act on. It's a response by the executive branch and a listing of what you need, and it's an exploration, this whole discussion about what we need to do going forward. I think that's a valuable exercise. Again, I don't have the answers to all that, but I think this moved us in the right direction in this hearing, and certainly the manner in which each of you have discharged your responsibilities to the country, quite frankly. And I thank all three of you for doing that. Again, Madam Chair, good hearing. I think we made good progress.
Thank you very, very much, Congressman Cole. Let me just do a couple of housekeeping things, if I might. This is with regard to two letters to HHS. There was a letter sent by the ACLU regarding the influx facilities. That was flagged for the administration, so we can get you further information on that. Also, if you could respond to a letter that was sent by public health officials regarding the flu vaccinations. The vice chair and I flagged this letter for HHS as well. So we're waiting the response on those letters, so if we could get that, that would be terrific.
Madam Chair, do you have some dates on those by chance?
We will get that to you.
Okay.
Yeah, no question. And I will be wanting to just to submit some questions for the record. You do not have to address these. It's because TVPRA has mandated post-release services that I understand that there are hundreds of children who qualify and they are on a wait list. If we can just know how long the children are waiting before they are connected with post-release service, and have the wait times increased. Again, we'll get you the questions. You don't have to. And what are the efforts that ORR is taking to expand the post-release services capacity and the use of the $2.9 billion in the supplemental, and how we go forward for 2020. You know, and I will get a couple of other questions, which I know that have to do essentially with post-release services. Let me just comment on a service that Congressman Roybal Allard mentioned to me, that there's something of a traveling nurse program where there is a pool of nurses who you can apparently tap into and that are available. They get back in less than a day, et cetera, and we can find out more about that and link that up with you in terms of services, because I am continue to be interested in the kinds of direct services that you are able to provide. And just as point, it's less than $600 a day for the nurses. So let me come to a conclusion here today. I really so sincerely thank you for the time and the thoughtfulness of your testimony and the thoughtfulness of the work that you do every day. I think one of the things that we have established and is that administration's policies, in fact, have traumatized thousands of children. I'm not going to dwell on that. I dwell on it a lot, but I think we do need to move forward. But I think we have established that some of these policies have put children at grave risk. And so the fact is that how do we try to deal with it? And Commander, you spoke about prevention, just as you talked about. And how do we prevent this from happening? You also did something very special, I think, Commander. So often, we all hear that these children are programmed to tell us a story about what happened to them, and they're just given a line, and whether it is a coyote or someone else who got them here or how they got here, that they and that they are parroting something that someone told them to say in order to gain access to the United States. One of the things that you talked about were the horrific circumstances that some of these children have faced. Congressman Roybal Allard pointed out the directives that some were given. So it's not made up. There's a reality here, which I believe we have to face and have to address and deal with in a humanitarian way. And again, that we added to that trauma for these children. We have to take responsibility for that. And I too, someone said, my colleagues will tell you on both sides of the aisle. I suppose I'm an, equal opportunity antagonist to whomever is in the White House, because we have to do what is right. Improvements have been made. and take credit for the directives. But as we know from the testimony, that there are current policies that we need to address. And specifically, I know I'm a broken record, but the memorandum of agreement, it's got to go. Let's find out who has that authority. I know what the assistant secretary said. She would rescind it. Let's do that. Let's do it and make the changes. Accountability is where we need to go. And we talked about that, and Chairman Cole spoke about that, as well as where do we go subsequently here to follow up, to make sure of what's happening here. We have to carry out the recommendations. Concurrence with the recommendations is not enough. And I say that to you, both of you. I say that to the IG, and you are following up, and that is our responsibility as well. It's not here today, gone tomorrow. We cannot forget about it. We cannot forget about it. You have tough jobs, very difficult jobs, but you have a lot of good people who want to do the right thing. And we need to work together, and I will commit to you, as we have in the past, that with regard to services, if we're going to be carried out, we'll have to provide the resources for that. Because this, it was wrong. I also would talk about the discharge. I am singularly focused on the discharge, and I believe we can do it. We've been able to do it. We've demonstrated that we can do it, so that we do not need influx facilities, which are not state licensed, but that we have a way, and will help to try to make sure that we have state licensed facilities that can deal with the issue, rather than case managers, people taking care of kids who have not checked out, have not been vetted the way they should. Let's follow both the letter and the spirit of the law where we want to try to address these issues. You know, and it is the state of Texas, I would just say, defines child abuse as inflicting or failing to responsibly prevent others from inflicting mental or emotional injury, impairing a child's growth, development, or psychological functioning. And I'm not saying this to you because you have trying to take us down a good road, but people have to be accountable. Those who employed a policy that would take us in this direction have to be brought to task in some way. Let's not follow a path of child abuse. No one here wants to do that. That's not what you came to do in terms of your public service. It's not who you are. So let's use the power of the agency to make the decisions about what happens to those children who are in our care. And let's make sure we take good care of them while they're here, and make sure they have good care when they are discharged, and to discharge them as quickly as we possibly can and safely as we possibly can. I want to again say thank you for your time, for your commitment, and that concludes today's hearing.